All right, so I'm going to talk today about ILIF, which stands for Intralaminar Lumbar Instrumented Fusion, as well as inner body techniques and prostheses. Those are the two things I'll talk to you about today. One of the things surgeons are always trying to do, they're always trying to find better ways to treat patients, just like Nick just said. We want to try to find things that are less invasive, better outcomes for patients, less morbidity for the patient, actually get them back to work a lot faster. And one of the things that we've run across, one of the problems that we have in spinal surgery is instability. Instability can come from two different ways. One is there's a spondylolisthesis, which is degenerative or traumatic, or it can be an iatrogenic. An iatrogenic means surgically we have to actually sacrifice sections of the spine, and it creates instability. And a lot of times to fix the instability, we have to create fusion. And these instrument fusions sometimes is the cure worse than the disease. I don't know if you've seen some of these scenarios with these wide open procedures, a lot of soft tissue damage, and that's why we want to go to these more minimally invasive approaches. So the ILIF is a technique that actually solves that. It's less disruptive, you can provide fusion, and also provides a robust fixation that allows for it to be instrumentation and hold the spine in line while it goes on to heal. Now, why is it important to have less soft tissue disruption? If you can imagine, as you open the spine up, take all the soft tissue off, it actually creates inflammation, swelling, it's more painful, longer recovery periods. It's a longer issue. So, in terms of fixation, one of the things you have is large pedicle screws in the past that hold spinal stability. Well, we had this spinous process plate, which I showed you. Well, is it actually strong enough to hold the spine in a good alignment while it goes on to heal? This biomechanical study showed that it's actually as good in flexion extension and axial rotation, and as strong as an intact spine and lateral bending. So they actually, even though it's minimally invasive and a lot less metal, it actually is biomechanically stable to hold the spine in good alignment. So when we go back to the lab, you're going to see that this medialized approach, which is where we're going to go in and dissect the spine, dissect the muscles off the spine, and you'll see this is where a standard ILIF procedure will actually dissect from this level, but a standard pedicle screw you actually dissect all the way over to the transverse processes. That much soft tissue damage actually causes a lot more morbidity. This picture here shows you what ends up happening in terms of a medialized approach. When you go down the midline, you only dissect out to what are called the set joints. We'll see that back in the Cadaver lab, where you don't go all the way over. When a standard pedicle screw, you're going to go all over the transverse processes. And again, that extra degree of dissection causes quite a bit of soft tissue destruction. Here's an example of an incision for a standard ILIF exposure. It's no bigger than the size of my thumb. Your traditional approach, much more morbid. You can see where it's much larger incisions, a lot more soft tissue damage to get that done. And when you have less soft tissue damage, again, less pain for the patients and improved outcomes. Here's what it looks like after they actually heal. You can see the incision is no bigger than the size of my thumb, where before it's pretty sizable incision. So this new technique, surgical technique, actually has improved patient outcomes. Now, one of the things you'll find when you're doing a fusion, it's not almost so much, sometimes you have to actually get an inner body fusion, which is in between the vertebral bodies, providing anterior column support. And there's different ways of getting anterior column support, either going from the side, it's called an X-lift, you may have heard of some of those. There's an A-lift where you're going from the belly, and there's standard T-lift or P-lifts where you're going from the back, but it's an approach for which we get an anterior column support. Now, when we're doing this, there's, again, using the same concepts, surgeons are always trying to find a better way to get better outcomes for patients, and that is to get a solid fusion. And there's a company called Titan, they're one of our sponsors, but they have a new patented technology that actually has improved for patient outcomes from improving their fusion rates. And it's a subtractive technology that actually creates an environment that incites bone formation to occur. To understand how they have differentiated themselves from other inner bodies, you have to understand how bone is actually formed. There's some type of insult, whether it be a fracture, whether it be a surgical approach, and when you create that, there's these things called osteoclasts that go in and reabsorb that damaged tissue. They create these osteoclastic pits, which promotes these cells called mesenchymal stem cells that come in, differentiate into osteoblasts, which lay down osteoid, ultimately mineralize to create new bone. So what they've done, they actually taking the same concept. There's an osteoclast in an electron microscopy creating these osteoclastic pits, where osteoblasts, those cells, all the way down to a cellular level, are attracted to these that lay down new bone to create a nice solid fusion for the fusion to occur. What they've done is they've actually mimicked that. They've used this technology to take titanium, do a subtractive technology where they actually create these osteoclastic pits, similar to what happens normally. It's kind of a biomimicry, they call it. And because of that, these cells promote the fusion. They did a study, which is interesting. Not all things are similar. They looked at the difference between peak. Now, peak is polyethyl ketone. You guys have maybe heard about people doing spinal fusions where they put peak in. Or they may have titanium cages, and there's this. There's been millions of cages put in this way. And this is a newer technology recently. When they looked at these different types of surfaces for the interbody fusion, they're not the same. When you look at it, they took mesenchymal stem cells and placed them on these different types of surfaces. And all the surfaces are not equal. The peak surfaces created these linear fashions more closely related to fibrous tissue, even at 24 hours, where the actual subtractive technology created cells that are more closely related to osteoblastic differentiation. When you go from 24 hours up to 7 days, you can actually see that these tissues become more closely related to fibrous tissue over something that looks more like bony tissue. So it turns out that this technology they've created or have is different. And it's different from what's already on the market today. This actually panned out. There's a study that was put out in 2015 in Spine that showed that the surface technology has a difference in terms of what the outcomes are for patients. The polyethyl ketone, the peak, promoted fibrous tissue, where the subtractive technology promoted bone formation. So, what we all want to try to do is try to avoid this idea here, whether we do a fusion with instrumentation, but you want to not allow non-unions to occur. So this is an example of a CT scan someone had peak where it did not heal. So they had a non-union at each one of these levels. There's no bone formation across the two surfaces. What you want to promote is something like this, where you have true surface integration of the bone go all the way through, and there's no evidence of subsidence. So these two technologies, whether it be the fusion technology with ILIF or the interbody fusion technology, all these things are done in a minimally invasive approach to promote fusion. Questions? Yes, ma'am.
So you can use that same cage whether you do a T-lift or P-lift?
Yeah, so the question was, can you use that same cage for T-lift, P-lift? Yes. These cages are made in different ways. It can be done in different ways, whether it be an X-lift approach, an A-lift approach, or a P-lift approach, or a T-lift approach. The cages are made differently so they can put in that way. But it's the same surface subtractive technology is still there, though. Any other questions? Because more fun it's going to be actually when we go back to the lab and actually do the actual surgery. So this is just to give you an idea of what we're going to do back in the